Hello and welcome everybody. This is, of course, the VCCC Breast Cancer Grand Rounds, and we are very happy to welcome you to today's seminar. So first of all, my name is Kylie Gorringe. I'm a group leader at Peter Mac, and I'd first like to acknowledge the traditional custodians of the lands on which myself and today's presenters and audience are located. For me, that's the Wurundjeri people. I'd also like to pay respect to the elders, both past and present, and to extend that respect to any other Indigenous Australians present online. So just a few housekeeping notes. We're recording the session. It will be available on the VCCC Alliance Open Learning page, and there's other previous webinars there as well, which is a great resource if you miss it. If you have any questions, we're going to do this by a Zoom Q&A function at the end of the seminar, but as our speaker is talking, feel free to start typing things in before so that we can have some questions ready to go as they occur to you. Today, of course, we are very pleased to have Professor Sherene Lo with us, who really doesn't need much of an introduction, as I'm sure she's very well known to everyone online today. You know, Sherene is clearly an incredibly internationally well-known and well-respected both clinician and researcher with a very active breast cancer research program at Peter Mac, and of course a lot of involvement in local and international clinical trials. And I believe she's going to focus on the clinical aspects of her work today. So welcome, Sherene. Thank you very much. If you want to turn on your camera and share your slides, that'd be awesome.
Can you see the right screen, or do I have to change my display settings?
That's great, thanks.
It's good? Okay. All right, so hi everyone. Thank you for listening, and it's a pleasure to be here today. I'm going to give a talk today about immunotherapy in the treatment of early stage triple negative breast cancer, and that's because this year we finally received approval by the US FDA for immunotherapy in this treatment indication. So that's very exciting for breast cancer patients. These are my disclosures. So as background, there is quite a strong rationale for the use of immunotherapy, particularly in triple negative breast cancer, which I'm going to focus the talk on today. So whilst breast cancer has not traditionally been considered immunogenic, and that's because the risk factors for breast cancer are reproductive, thought to be predominantly reproductive and hormonal, that is related to number of children you've had, breastfeeding, pregnancies, etc. Unlike the more immunogenic cancers such as melanoma and lung cancer, but triple negative breast cancer has long been noted to have a high lymphocytic infiltration. And the reasons for this have not really been clear. My lab has published that this TIL infiltrate has high expression of PD-1 and other checkpoint molecules, particularly CTLA-4. And this forms strong rationale for the use of PD-1, PD-L1, and CTLA-4 agents in treatment of breast cancer, particularly triple negative breast cancer. So breast cancer has been one of the last to have immunotherapy evaluated in, and it's only this year that the readouts for the early stage triple negative breast cancer studies have been reported. And I'm going to give you an update on that today. So I guess just as a bit of background, is there strong rationale to use immunotherapy in the neoadjuvant setting? That is when the breast cancer is present prior to surgery. We do this with chemotherapy quite frequently. Or is it better to use immunotherapy in the adjuvant setting? That is after you remove the breast cancer. And we have traditionally given chemotherapy in the adjuvant setting. So there's not a lot of evidence to guide this guide us preclinically, but there was a publication by Mark Smith and colleagues, and this showed that actually the neoadjuvant model, so giving the immunotherapy prior to surgery when the breast cancer was in situ, was better with regards to improved survival of the mice from cancers. And this was because there was greater antigen creation, there was greater quantity of tumor-specific T cells, the presence of the tumor resulted in greater expansion, and the T cells were more functional after the tumor was removed. From a practical viewpoint or from a clinical viewpoint, the neoadjuvant route is actually a faster route for accelerated approval, and you get the result or the PCR endpoint very quickly compared to after many years. So the studies I'm going to discuss today are three phase 3 studies. The Keynote 522, which was performed with pembrolizumab, that's the largest study, and the Neoadjuvant and Impassion 031, which was performed with atezolizumab. I also mentioned two smaller phase 2 studies, particularly the Genomics study, because this also has reported their long-term clinical outcomes, which is event-free survival. So this is a summary of the trials that have been reported. So Keynote 522, the primary endpoint was both PCR, so that's pathological response at surgery, as well as event-free survival, so breast cancer recurrence. And this has been reported this year as being positive for both endpoints. This was a study, the largest study, over 1,000 patients with early stage triple negative breast cancer. Impassion 031 and Neoadjuvant were much smaller phase 3 studies. Impassion was only powered for the PCR endpoint. That also has been reported as a positive study. And Neoadjuvant was powered for the longer term endpoint, and that has not yet been reported for that endpoint, but the PCR endpoint has been reported. Just highlight the German study, the Genomics study, which also reported both PCR and event-free survival endpoints, but this was actually reported as negative for the PCR endpoint about a year or so ago. So the studies are very different in their design. So this is the Keynote 522. This gave a very intensive chemotherapy regimen. So this was carboplatin and Taxol, followed by anthracycline or AC chemotherapy. Patients were randomized to pembrolizumab or placebo. They had surgery after 24 weeks and then were then continued pembrolizumab or placebo for a total of 1 year. The atezolizumab Impassion 031 study was a little bit different in that it did not give carboplatin, it used nab-paclitaxel, followed by AC. They had surgery and then they went on to receive atezolizumab or observation for a total of 1 year. And the Neoadjuvant study, which was a different chemotherapy regimen, was carboplatin and nab-paclitaxel, so no anthracycline. And this was given for a total of 24 weeks, followed by surgery, and chemotherapy after surgery was up to the investigator depending on the results. So here's a summary of the different chemotherapy regimens. So they're all quite different. The agents are different. And I'll just highlight for the clinicians in the audience that there was varying use of platinum. So the Keynote 522 was probably the most intensive chemotherapy regimen. But this study did not have any capecitabine post-operatively, which is important because now we frequently use capecitabine for those patients who have residual disease. Impassion 031, whilst it continued atezolizumab, it did allow capecitabine in both arms. And the Neoadjuvant study allowed traditional anthracycline-based chemotherapy post-operatively. So we have a variation, varying different types, varying different treatments, both pre and post-operatively. So I'm going to discuss PD-L1 status. So PD-L1 is the expression of the PD-L1, which is the target of these agents. And PD-L1 is assessed by immunohistochemistry. The problem in many of these studies is the assays are different. And as a result, the population that's designated PD-L1 positive is different in each study. And you can see there, depending on the assay used, the number of patients classified as positive is actually quite different. So the Keynote 522, which uses a CPS assay, which counts PD-L1 positive cells in both the tumor and the stroma, use a value of 1 or 10 as positivity. And you can see if you have a score of 1 or more, over 80% of the population is positive, compared to 10 or more, which is around 50% of the population. The atezolizumab studies, Roche Genentech used this SP142, which only counts the PD-L1 positive cells in the TIL or in the immune infiltration. And as you can see here, the patients designated as positive is far less than those considered positive by the Merck assay. And the German study, which used an AstraZeneca PD-L1 agent, again, a different assay and a different amount of patients classified as positive. So of course, this is very confusing because we don't really know what the truth is, and we can't really work out how PD-L1 status relates to ultimately the endpoints of the study and who actually benefits the most from the treatment. And if we look at advanced disease, so patients who've recurred with metastatic disease, the levels again are different according to assay. and according by line of treatment, which does suggest some loss of immunity as we go further down the disease course. So here's a summary of the trials and the disease characteristics, and I've just tried to summarize the tumor stage per trial, but it's just to highlight that the Passion 031 and the Keynote 522, which were the largest trials, were very similar in their disease characteristics, in that the majority of patients had T1, T2 disease and no negative disease and stage 2 disease, as seen here. This is in contrast to the Neoadjuvant study, which actually had a much higher burden of disease. They had far greater T3, T4, no positivity as stage 3. And this is important because the first endpoint that's reported, the PCR rates are lower in patients that have stage 3 disease. And the Genomics study, which is a small German study, actually had a high proportion of lower burden disease. Okay, so what about the first results? And that relates to PCR, so the absence of invasive tumor at surgery. So this is the endpoint used as kind of, we think it may be a surrogate for other treatment types and give us an early readout of the efficacy of treatments. And the FDA has used PCR as a means for accelerated approval. So this is, of course, is very important for companies in order to get their medication to the public quickly. And here again, I've tried to summarize the various results according to study, but also according to PD-L1 status, so PD-L1 positive versus negative. And that's important because in the advanced disease, it was only really the PD-L1 positive patients that seemed to benefit from the addition of these agents. So we're very keen to see if this translated also to the early stage setting. So the thing to note in this study is that the control arms in most of the studies that did not include the carboplatin, so the 031 and Neoadjuvant and Genomics, performed about the same. And that is interesting considering that the Neoadjuvant, of course, did not have the anthracycline and had 24 weeks of just carbotaxol. If you look at the NCI study, this had a much lower PCR for the control arm, and that was probably because it had only 12 weeks of therapy versus 24 weeks in the other study. The other thing to note is that the carboplatin here in the Keynote 522, it increased the PCR rate in the control arm, but did not seem to affect the change that was added to by the addition of the pembrolizumab agent. So carbo adds to the PCR rate, but it doesn't seem to make a difference to the benefit for the addition of pembrolizumab. PD-L1 status is important. It's clear that PD-L1 is prognostic. As you might recall, PD-L1 is expressed on the immune cells. So if you have more immune cells, you do better. We've known that for a long time now. And you can see here that in the control arm, the PD-L1 positive patients perform better compared to the PD-L1 negative patients. However, PD-L1 did not seem to make a difference to the benefit. And you can see here that if you're PD-L1 positive or negative, you derive benefit from the addition of these agents, particularly in the larger studies. And I will highlight here the NCI study, which only had the 12 weeks of carbotaxol, but you can see here that the addition of the tislelizumab seems to make a big difference in the change of the PCR endpoint. So the Keynote 522, as I mentioned, was the largest study. The data I've just shown you was reported at the first interim analysis, where the delta was 13.6%, so quite a small change compared to other treatment modalities that we've seen before, for example, with targeted treatment or chemotherapies. And again, there didn't seem to be any difference according to PD-L1 status. And if you look at the full population, so the 1,000 patients, you can see that this delta is actually quite small, so around 7.5%. Again, roughly the same according to enrichment of PD-L1, and not a huge amount of difference according to PD-L1 positive versus negative. So compared to what we've seen before, this change is very, very small. But of course, it begs the question, does immunotherapy actually mediate benefit for breast cancer survival through tumor reduction? Because it acts predominantly on the host, of course. And so we need to wait for the long-term outcomes, and that is of event-free survival or recurrences after curative surgery. And yes, so now we know that it actually is improved. So the Keynote 522, the mature data was presented very recently, but it was consistent with the first interim analysis, and that it showed that there was significant improvement in reduction of breast cancer recurrences and a median follow-up of over 3 years. And you can see there the hazard ratio of 0.63. Interestingly, the smaller Genentech Impassion study, as you might recall, this was only 333 patients. And while this was not powered for this endpoint, it shows a similar hazard ratio in the same direction. So benefit for patients to receive atezolizumab. And the German study, which was again not powered for the longer term endpoint, but has reported at a median follow-up of around 43 months. And you can see the hazard ratio there is significant at 0.48. So it halved the number of breast cancer recurrences with the addition of atezolizumab. And if you might recall, all of these trials had just very slight differences in their chemotherapy treatment as well as post-operative treatment. So I show you the data from the German study. So this is a smaller data study, and you can see here in pink for all endpoints, atezolizumab improved invasive disease-free survival as well as distant disease-free survival and overall survival in patients that received atezolizumab. So as clinicians, we're very interested in what happens to the PCR patients compared to those who have residual remaining disease. So PCR suggests that those patients have very sensitive tumors to the chemotherapy. And you can see here that if you particularly look at patients in distant disease-free survival, patients in pink who achieved a PCR and received atezolizumab compared to the patients in blue here, who achieved a PCR and received placebo, you can see that their survival is 100% from overall survival as well as distant disease-free survival. There's a slight drop here in invasive disease-free survival, but that was due to in-breast recurrences. So, very, very impressive, 100% survival at 4 years for patients who achieve PCR. And this is why we like to get patients to PCR, because we know they're going to do really, really well. So this is the Jepa-Nueva study of note. These patients did not receive carboplatin and did not receive their immunotherapy, in this case, durva, post-operatively. So let's look at the Keynote 522, because this was the registration study. This was powered to look at the final endpoint, which is event-free survival. And over 3 years follow-up, you can see that pembrolizumab significantly improved event-free survival compared with patients who received placebo with a hazard ratio that was 0.63. And just to emphasize how important it is to have multiple studies, so we know that the benefit is real, that this benefit, absolute benefit, was almost identical to that smaller German study that I've just shown you. This resulted in FDA approval of this treatment in August of 2021, and now it's increasingly being used in the United States. We are waiting, of course, for TGA approval in Australia. And what about PCR? So we know that PCR is important, as I've mentioned to you. It's very reassuring for patients if they've achieved PCR. You can see here the curves according to treatment received and if they did or did not achieve PCR. So you can see here that the important thing to note is that the addition of pembrolizumab in this study got more patients to PCR. It's still questioned, even though these patients all received pembrolizumab post-surgery. I think this is questionable given the excellent results of the German study. There is a small difference here. You can see around just under 2% in patients who received pembrolizumab compared to patients who did not, who achieved a PCR. Whether that's real, we'll find out. But of course, this study was not, we'll probably never find out because this study is not powered to look at those differences. But what about patients who had residual disease? So this is the presence of invasive cancer at surgery. You can see patients in the placebo. These patients do exceptionally, poorly. Nearly half have recurred by 3 years, and we know recurrence is almost always associated with death from breast cancer. And this is because, not surprisingly, their tumor was not as sensitive to the chemotherapy treatment. However, you can see the addition of pembrolizumab did improve this somewhat. This is quite a significant improvement, over 10% improvement, absolute. So it's really important that these patients have pembrolizumab pre-op, and probably important that these patients have pembrolizumab post-op. I will remind everyone that these patients did not receive capecitabine, so we're not sure if this can be moved at all, these curves, and that these patients, despite receiving pembrolizumab, are still doing quite poorly. So, you know, over 35% of these patients will recur by 3 years. What about in all the different subgroups? And we look at this to see if there's any differential benefit or if any groups seem to benefit more. And originally when we had the PCR reports, there did seem to be some suggestion that certain groups benefited more, but now we can see that in the event-free survival, pretty much all groups are deriving benefit. And I think this highlights that PCR is actually a poor surrogate endpoint for immunotherapy studies. You can see the absolute benefit here on the right, and you can see that the nodal status, all patients seem to benefit regardless of nodal status. T3, T4 perhaps had less benefit due to higher tumor burden. The carboplatin schedule was identical benefit. Most interestingly, the PD-L1 status, the positive patients and negative patients bizarrely seem to derive more benefit. For this, to me, the reasons for this is still unclear, given that patients with PD-L1 positive TIL have a far higher quantity of TIL present in these tumors. Age seemed to be roughly the same, as well as performance status. So all subgroups favored the addition of pembrolizumab. What about toxicity? So I think, again, we should not, gloss over the toxicity. We know that the addition of pembrolizumab does not interfere with the delivery of chemotherapy or radiotherapy. There were no excessive adverse events in these patients. There were, however, more discontinuations in the pembrolizumab arm. And this was because of the most common side effects due to immune therapies, which is related to endocrine adverse events. Particular thyroidism is present in around 20%. So these patients will require permanent thyroid replacement. And there's also the possibility of adrenal insufficiency, which is around 2% of patients. And these side effects are usually permanent and lifelong. And we know there are also some very rare but significant side effects of immunotherapy, including type 1 diabetes, Guillain-Barré, and there are side effects that we actually don't know anything much about, such as that on our fertility, particularly for this population who are younger than most other cancer populations. So this is a summary of the different types and the frequencies of the adverse events. And you can see here again, most commonly the thyroid dysfunction, adrenal insufficiency, pneumonitis, thyroiditis, hypophysitis, which again requires permanent replacement, also colitis and hepatitis. And discontinuation of these drugs was around 10% in the pembrolizumab arm. So what can we conclude? So the addition of these agents increased the PCR rate by a small amount, but the most important endpoint, or breast cancer recurrences, it improved that or reduced the rate of breast cancer recurrences by a lot, nearly a third. However, this suggests that these improvements in long-term breast cancer endpoints are not mediated through PCR increases. So this begs the question, how do we design the next generation of trials, particularly neoadjuvant trials, when we can't rely on PCR as an endpoint? We know the addition of these agents results in more patients achieving PCR, which is important, as well as improved event-free survival in patients who still attain residual disease. And it seems to me that these agents are best placed in the neoadjuvant setting, and we actually don't really know the role of these agents post-surgery, particularly for those patients who achieve a PCR. The presence of PD-L1 is prognostic. Higher PCR rates are present with these patients. And actually, ironically, those who are most likely to achieve a near PCR with chemo probably do better with the addition of these agents. It makes it very hard to either de-escalate chemotherapy or de-escalate immunotherapy. But I think importantly, PD-L1 negative patients seem to need these agents, and certainly I'm offering these agents to all patients in the clinic at present. It's not approved, but some patients can afford to self-fund. We suspect that benefit in the PD-L1 positive patients can be improved. It's unclear why we see these discordances, and it's unclear why PD-L1 negative patients seem to benefit more. Is this because that they can generate a new immune response against their tumor? This is one possibility. And can we optimize the chemotherapy? Do we need to give such myelosuppressive chemotherapy in the setting of immunotherapy agents? It seems to be a little bit counterintuitive, and therefore we need to do more investigation on the best chemotherapy backbone. The immune adverse events are a real concern. Perhaps we need to identify clear populations with larger benefit. The follow-up is still short for these studies, so we're not sure of the long-term effects of these adverse events, particularly the immune ones, which require lifelong replacement. Follow-up may be hopefully for 10 years in these pharma-sponsored studies, but that's unclear at the moment. And again, as I mentioned, this population is a younger population compared to most cancer studies of immunotherapy. Younger women do have more autoimmune disorders in general, and we don't know how long these AEs may occur, and we know they may occur long after the treatment has ceased. Just a quick slide on PD-L1 staining, just to highlight to the scientists in the room this situation of PD-L1 immunohistochemistry assays is really difficult for clinicians. We have 3 or 4 different assays that all give different results, and no one wants to make a call on them. So you can see here that you have your basic light microscopy, and you can see the TIL here. And you can see that the SP142 assay does stain the TIL, nothing else. But the 263 and the CPS assays, they have far more staining, you can see here. And they also stain the immune cells. So this is more sensitive, but this is more particular for immune cells, which may be better for breast cancer. Those that are stained positive by SP142 are contained in those that are stained positive by these other assays. But of course, we don't know which is the most therapeutically relevant one or which is the most biologically correct one. And this is the target of these agents. So why would patients who are negative for this actually respond at all? So I'd just like to show everyone the trials that we're doing in Australia with immunotherapy. This is an Australian-run study by Australian Breast Cancer Cooperative Group. Here we're looking at a shorter chemotherapy regimen. We're also looking at sequencing of the immunotherapy. So we hypothesize here that perhaps giving the immunotherapy up front will result in greater T-cell proliferation and expansion before we hit it with chemotherapy. We believe that less chemotherapy will achieve a PCR, and we know those PCR patients do really well long term. And here we do not give immunotherapy after surgery because we believe that if for those patients that achieve a PCR, that they will do well without it long term. There are many other studies ongoing in the world looking at immunotherapy, and we'll get more answers about the best setting and duration shortly or in the next few years. There are neoadjuvant adjuvant studies similar to the Keynote 522. There are also pure adjuvant studies, which is giving immunotherapy after surgery, so removal of the invasive breast cancer. So it'll be interesting to see the effect of these studies. And there's studies that try to give immunotherapy after surgery, so only to patients to those who have residual disease. So this may be one way, if positive, that we can either escalate or de-escalate our treatment, because of course all these treatments are costly, and for Australia will be ultimately paid by the taxpayer. So in conclusion, there's strong use for immunotherapy now in early stage triple negative breast cancer, but the optimal way is less clear. The current trial PCR and event-free survival results are very promising for routine incorporation into the early stage triple negative breast cancer setting. You can see it gets more patients to PCR, and that's an important aim. For those patients who achieve PCR, it's unclear what we do with the immunotherapy. For those patients who did not achieve PCR, we have a number of treatment options now, which I haven't gone into, but it's actually very difficult for us to decide what to do with these patients. We have yet to understand how we are going to individualize chemotherapy and immunotherapy for patients, given the possibility of adverse events. And these adverse events are not insignificant, given that we are now giving patients in the curative setting. And again, we need to do more research on the PD-L1 status. So in breast cancer, PD-L1 status is predictive in the advanced setting, but not predictive in the early stage setting. It's unclear what to do for patients with residual disease. They're still doing very poorly. We have a number of options, and we certainly need to do more research and studies in this area. And now, as we give these agents in the early stage setting, what is happening to the biology of these patients when they relapse? We're not sure if they will respond again to PD-L1 treatment or PD-1 treatment, and obviously more research is needed in this setting as well. So with that, I'm going to open it up for questions. I'd like to thank my funding body, National Breast Cancer Foundation, and I'll just highlight that the webpage for TILs in breast cancer is there, and you can find a lot of resources if you want to measure TILs yourself. Thank you.
Amazing. Thanks so much, Sherene. That was really great to hear. Not being a triple negative breast cancer person myself, it's excellent to hear the latest in immunotherapy. So just to everyone, just to remember to type your questions into the chat or the Q&A, and I'll read them out for you. So we've already got one that's come from Belinda, and she said, thanks Sherene, great talk as always. In Australia, do you think we are more likely to get funded access to immunotherapy in the EBC, not quite
Early
sure.
stage.
Early stage. Thanks for translating. TNBC or PD-L1 status setting, Neo, ? Rather than the advanced setting?
Well, I can't predict what Greg Hunt is going to say, but I know that Merck will put in their documentation for their filing for approval of pembrolizumab in both the advanced and early stage settings. I think for the advanced stage setting, it is associated with improved overall survival, so patients live longer if they express PD-L1 with the addition of pembrolizumab. That data is pretty compelling. If I was a patient, I would certainly want access to pembrolizumab if I was PD-L1 positive. And I mean, I think the early stage data is also pretty impressive for patients. And again, if I was a patient, I would be wanting to receive immunotherapy in the early stage setting as well, independent of PD-L1 status. So, but of course, funding decisions are not up to me.
It's interesting that you're drawing that difference between PD-L1 status in the different settings, because obviously it doesn't seem to be a good predictive biomarker in that early stage. Are there better biomarkers out there, and how can we discover them if not?
Yes, so breast cancer is a little bit unique that in the advanced stage, PD-L1 was such a predictor. It doesn't seem to be the case for melanoma, for example. So I mean, it makes sense that, of course, that if you're PD-L1 positive and you express the target of the drug, that you're going to respond to these agents. What's surprising is that that seems to be relatively fixed in the advanced setting for breast cancer patients. That is, if you're PD-L1 negative, doesn't seem at the moment that you can become PD-L1 positive and therefore respond to these immune agents. We have a number of reasons for that. You know, the burden of disease is very immunosuppressive. The host is unable to generate a new immune response. We give a lot of chemotherapy and radiotherapy in the early stage setting. It could be that T cells, you know, we deplete all the naive T cells, so we can't generate a new response in the advanced stage. And, you know, I think we may have to look at other therapies such as CAR-Ts or adoptive cell therapies, but, you know, we have the problem that the local tumor microenvironment is very immunosuppressive. So even if these T cells can get in, they can't really exert their cytotoxic abilities in that setting. In the early stage disease, we have a tumor confined to the breast and we remove the tumor. So we remove the antigen, which probably is beneficial for T cell function ultimately. So it could be they're naive, and naive patients have a better response to immunotherapy and chemotherapy agents. But it is a bit confusing because, you know, we know that PD-L1 positive patients, they have a lot of TIL, right? So we know that quantity of T cells matters. So we're working on a theory that chemotherapy may be detrimental in some of these patients. But at the moment, if you're in the clinic, you'll be giving chemotherapy and immunotherapy together.
Yeah, for sure. So a question from Prue, how does this fit with attempts to de-escalate chemo without immunotherapy in T1 node negative with high TILs?
Yeah, so we've published that, you know, if you have high TIL or high PD-L1 or high PD-1, that you do pretty well without treatment, with treatment. So it's prognostic if you've got an immune response to your cancer. So at the moment, it's unclear which is best to de-escalate chemotherapy or immunotherapy, given some of the adverse events, but also chemotherapy can be associated with long-term impairments in quality of life as well, and also the risk of secondary leukemias and cardiac toxicity long-term. So I think, you know, with our patient advocates, we have to make a decision on whether they want to de-escalate chemotherapy or whether they want to have chemotherapy as opposed to immunotherapy. I mean, ideally, we know the patients that are immune enriched, that is high immune infiltration, high levels of PD-1, high TNB, I mean, they're going to do probably very well from immunotherapy just on its own, right?
Mm.
But you can give a dose of immunotherapy and you can blow your thyroid in the one dose. So, you know, we can't predict who's going to get an adverse event from that point of view. Interestingly, we have data that if you do have thyroid dysfunction, you actually do better with your immunotherapy because there seems to be some cross-reactivity with the antigens in your thyroid and your breast cancer. So we're in a bit of a bind, and I think, you know, patients will need to help us try and make that decision about which to escalate and de-escalate.
Yeah, highlighting the importance of the consumer in this discussion. So I've got another question from Belinda, which is, how important is the adjuvant immuno-oncology, the German DERVA study is really interesting.
Yeah, so at the moment, I don't really think there's a role post-operatively. I think Merck will tell you otherwise. We'll never have that answer because we'll never randomize a study like that. But I think if the German data holds out, and that survival now is nearly 5 years, I think that's pretty compelling data. That if you achieve a PCR and have no post-operative treatment, you have 100% distant disease-free survival and overall survival. You can't get better than that.
Yeah, for sure. So just a reminder to people, if you've got questions, please do type them in either to the chat or the Q&A. I guess I can ask another one, which I think, you know, given the high level of adverse events with the current immuno-oncology agents, there's presumably not really a benefit in trying to introduce this in a pre-invasive or pre-malignant setting, because it would just be so much more high risk than the actual disease itself. But do you think, looking forward, are there other ways that you could target the immune system to control those conditions? Because they have a lot of them have a lot of TILs and a lot of immune activity in that microenvironment, whereby you might not have to give them radiotherapy, or you might even not have to give them surgery.
Yeah, no, that's an excellent question. So it's very, very interesting. We do see a lot of immune infiltration in VCIS, of course, particularly certain types. And it does seem that, the quality of that immune infiltration changes as patients move toward pre-invasion and invasion. So it's a very interesting question. And certainly I think, well, the San Francisco group have a study of DCIS where they do give 1 dose of pembrolizumab, but the problem with those studies is that the readout for the outcomes takes so long, and DCIS, as you know, is very heterogeneous. So, we might never know.
Yes.
But yeah, it's very tempting to think about, particularly the BRCA patients, of course, because they're heavily immune infiltrated. So it is very, very tempting to think that that might work in that setting.
I mean, could you do it in a kind of like pre-surgical session where you could then look and say, okay, well, what happened? We've got our biopsy. We know what it looked like then. What happened to it after, or even with some kind of imaging? So can you see changes that way?
Yeah. So I mean, I think that's again a great idea. The issue is what you're going to use as your readout, right?
Yeah.
So what tumor changes or peripheral changes will convince you that the patient has generated an immune response, right? So, and is that response going to be long lasting? So we have looked at peripheral blood markers. So there is some data that increase in CD8 positive PD1, Ki67 T cells in the periphery may be a marker of something happening to your immune response. Is that going to be tumor specific? Who knows? Then we have to do TCR sequencing, and then probably you have to follow up with some sort of TCR sequencing, several years down the track, right? So yeah, these studies are very, very complicated, but if someone's going to fund them, they're going to do them.
Yeah, and I guess that long-term follow-up as well, as you say, for younger women who had that potential to develop some kind of autoimmune condition is really. Yeah, so it's hard to. It'd be a brave company, I guess, that would go and take that on. So just got a comment, I think, from Prue saying, a question. Do we think IO works better with tumour still in situ?
Yes, I think most people do. Is the bottom line. Yeah. So I think other tumour types are starting to do this now, and there's certainly a lot of biological rationale for that, I think. So yes, we believe it's so. Saying that, the melanoma pembrolizumab adjuvant studies have been reported as positive. So it does seem to work in the adjuvant setting where there's microscopic cells present. saying that, I think melanoma is very different from breast cancer because it's far more visible to the immune system.
Yeah, for sure. All those neoantigens floating around. All right, well, it looks like we may have run to the end of our questions. Just very last, if anyone else got a burning question they want to ask now, otherwise it'll be too late. But thank you so much, Sherene, for your talk. It was really great to hear from you. And otherwise, if there's no more questions, we will finish there. Thank you very much for attending. Don't forget, there'll be additional breast cancer ground rounds coming up in the future. You can see this QR code, which will let you register for other events. And yeah, see you next time. Thanks very much, everybody. Thanks, Sherene.
Thanks, everyone. Thanks, Holly. Bye.